So most of these are straightforward cases, but I just clustered them just so we learn about one entity at least in one conference completely. So this first one is older patient. I will withhold the history for now, but came in with abdominal pain.
I saw some nodular thickening in the small bowel loops.
Okay.
Yeah, looks like there's an intussusception.
Okay. And then upstream.
Proximal bowel dilatation. So intussusception, probably there's a lead point, there's some soft tissue. There's a soft tissue mass, probably that's causing the intussusception, and then upstream bowel obstruction.
So she presented like a gastric outlet obstruction type. Like you said, there's a big air fluid level in the stomach. D1, D2 are all dilated, and then abruptly we see narrowing at this D3-4 junction, and then duodenojejunal junction. Ligament of Treitz area is, just as you said, there is an intussusception, small bowel to small bowel, we see it go in here. And then there is a hypodense lead point. And then there was another.
How old was she?
She was older, 60 something.
Okay, melanoma mets can do this.
Okay, that's a great thought. So commonest small bowel tumors are, one of the commonest, I guess, is metastasis from melanoma. Primary adenocarcinomas of the small bowel can cause intussusception like this. And interestingly, when we went back years ago, she had actually had an acral melanoma that had been removed. So she had been disease-free from her acral melanoma, and then years later, she presented with this gastric outlet obstruction from a small bowel melanoma metastasis. We always think of a few different ways in which melanoma mets can present. This is one of the ways in which it presents is as like a polypoidal mass. The other way in which melanoma mets can present is actually circumferentially like this, which actually results in aneurysmal bowel wall dilatation. So similar appearance with lymphoma or other adenocarcinomas, but melanoma mets can cause this concentric involvement and small bowel aneurysmal dilatation. This was part of a PET CT, so the resolution is not great. Then I have a companion case here for a similar entity, but
So a fatty mass now causing intussusception, and bowel lipomas are known.
right. So this was a colonic lipoma, long segment. I'll probably pull up the coronal, which is more impressive. So this was a colonic intussusception from a large colonic lipoma. It kept going, and the lead point is over here. So colonic lipomas are also common. So in the colon, the other causes that can cause colonic intussusceptions are polyps, adenomas. Sometimes we've seen vascular malformations that can be lead points. In the small bowel, other things that can cause this, of course, are lymphoid tissue, small bowel vascular malformations, and then enlarged lymph nodes from whatever cause. Varices, like from portal gastropathy or portal enteropathy, can be other lead points. And this last case was kind of an interesting one. So if you notice outside the abdomen, if you look at the cutaneous surface, you'll notice patient has multiple small abdominal wall nodules. So that would make us think of NF, neurofibromatosis. And then in the pelvis, we found this really large mass, which was also causing a small bowel to small bowel intussusception. So one of the thoughts we gave as a differential was, could this be an MPNST in the setting of extensive neurofibromatosis, which had caused a small bowel to small bowel obstruction? Patient also had volvulus, which was contributing to some of his small bowel symptoms. Eventually, this mass came out, and this turned out to be a neuroendocrine metastasis causing a small
Oh,
bowel to small bowel intussusception. We were hoping it would be a neurofibroma that would have kind of tied up the cutaneous findings really nicely, but it ended up being a small primary in the lung and then this large met. So the teaching point is that metastasis from any organ can pretty much go into small bowel, and they can be the cause of symptomatic intussusceptions where there is a lead point. So anytime we see an intussusception, it is our job to look for the lead point, try and characterize the lead point, and then try and see, is this a primary, is this coming from somewhere else? And then the other thing, just as a refresher, was that melanoma mets can be a cause of aneurysmal dilatation of small bowel.
yeah, very interesting. Yeah, I also remember a case a couple years ago. Elderly person presented with large bowel obstruction and had 3 sites of intussusception at the same time along the colon. We strongly thought of a lead point, but just couldn't see much on CT. And when he was operated, they found melanoma mets resulting in intussusception and causing large bowel obstruction. So yeah, that's an important cause to consider for bowel obstruction with intussusception. To look
Right.
for lead points, that will be important. Yeah.
And this is a great article I found, which talks about a lot about intussusceptions without lead points and intussusceptions with lead points. It has lots of good pictures, and then radiology assistant has a bunch of these are similar to our case. This is the polypoidal variant with intussusception. This is the aneurysmal dilatation variant with intussusception, both cases of melanoma also. So if anybody wants to read more, this is a good article I would refer you to. That's all I have. Thank you.
Thank you, Roopa. Nice cases. Does anybody else have any cases to share?
I have one case. This is Nelly.
Hi, Nelly. Yeah, sure. Go ahead.
Okay. Okay. So what do you guys think about this lesion? Hello? Can you guys hear me?
We can't hear you well, Nelly.
You cannot hear me well. Let me see. So what do you guys think about this liver lesion?
Just slightly T2 bright, shows intense
Yes.
arterial enhancement. Looks like there's a central scar. So once, like I want to say FNH, but I'm just looking for those lobular margins.
Yeah, so like for me, sometimes I have a hard time differentiating FNH from adenomas because adenomas can enhance too. And they can persist, you know, on portal venous space, especially the inflammatory adenomas. And
Yeah.
of course, like, you know, the ideal situation is that we have an EOVIS phase. And in this case, we do have an EOVIS, and there's uptake on it, which is a diagnostic confirmation right there. So, you know, exactly. So I looked into sort of like, how do you differentiate an adenoma from an FNH if you don't have a hepatobiliary phase like we do in this case? So I learned a few things which I thought was really helpful to me at least. So there are sort of morphologic ways to differentiate an adenomas from FNH if you don't have a hepatobiliary phase, and these are some of the things that I found from this paper. So like you said, FNHs, they have lobulations. They're sort of like, I guess, subtatus cyst equivalent, you know, versus adenomas, which are typically round. They're not lobulated. And they sometimes can look encapsulated, I guess, like a cystadenoma. Like, you know, sometimes we have a hard time differentiating a septatus cyst from an MCN. And septatus cysts are lobulated versus MCNs, which are typically encapsulated, round, non-lobulated. The other thing that I didn't know was that adenomas, they have a centripetal fill-in of enhancement. So because there's little arterioles along the margins of the lesion, and then the arterial system then fills in kind of like a hemange, but I mean, it doesn't have the nodular enhancement like a hemange, but it's a centripetal fill-in from the capsular arteries versus FNHs, which is centrifugal, so it fills from inside out. So there's a really great radiopedia contrast enhanced ultrasound images that I'm going to show you of an FNH that is filling in centrifugally. So scroll. I'm trying to scroll down on my Explorer, but it's not working. Oh, it's still loading, that's why. Okay, so here is a great, oh man. Okay, it's an FNH. This is from Radiopedia. And it shows the centrifugal. So it fills in and it goes out. So FNHs have a centrifugal fill-in of contrast enhancement if you have dynamic images like with contrast enhanced ultrasound versus adenomas, which fills from outside in. So, and then as you mentioned, like you get the scar, right? You get FNHs have central scars. They are, and they can enhance on delayed images. So I think those, so morphologic findings, I think can help. So in this case, so you don't always necessarily need EOVIS. So in this case, this patient did have lobulated margins. The enhancement, you know, it's not going from outside in. You can see it's like a homogeneous inside out. I mean, we don't have dynamics in this case, unfortunately, but, you know, and then of course, what else? The central scar, like you said. So these things would then help you lean towards FNH over, say, an inflammatory adenomas, which also enhances and can persist on delayed images.
So Nelly, I thought that it was more of an adenoma because in one of your images, it looks like there is fatty infiltration of the liver. So.
Oh, you know, let me see if I can share that again so we can like review what you just. So let me get the in and a post face because you were mentioning. Where's my in and post face? In the in and a post.
Do we have in and out of phase? Yeah,
there is a little bit of hepatic steatosis. There's no intralesional fat, so at least like if this was an adenoma, we know this is not the HNF1 alpha subtype. But yeah, no, I don't know that hepatic background steatosis necessarily makes it adenoma. I mean, yeah, for sure, OCPUs and whatever.
Right. I mean, it was just more because I mean, as we know, anything can have a scar. You know, adenoma can have a scar.
Yeah.
FNH can have a scar. HCC can have a scar. A hemangioma, pretty much anything can have a scar. So,
yeah.
So it is a tough.
Not helpful.
It is a tough thing. But if this centrifugal thing is there, that would be helpful, and that might be a good thing for people to start doing more contrast enhanced ultrasound also.
Yeah, and the lobulated margins, right? So like this FNH, they have these lobulated margins versus adenomas, which are more encapsulated. They look like a little capsule.
Yeah, it's always difficult to differentiate if they don't have classic imaging findings between an FNH and adenoma.
Yeah.
One of the ways to troubleshoot is to do EOVIS, but again,
another study, yeah.
Yeah, but EOVIS, I think it's helpful only when we don't see uptake, then you know it's not FNH for sure. Because if it takes uptake, then you're not sure, is it an FNH or it's a type of an adenoma. There are some types of adenomas that show EOVIS uptake, like the mixed ones, the beta-catenin, HNF1 alpha combined adenomas can show EOVIS uptake. So, and then we again have to go back to our conventional imaging and look for these findings if they're more of stealth lesions on other phases and they have these lobular margins, and if you have a central scar and then you have an EOVIS uptake, then you are more confident that it's FNH. And adenoma, again, it'll show EOVist uptake, but it doesn't, the pattern of EOVist uptake in an FNH and an atypical adenoma is slightly different. But again, it's the conventional imaging features that help you: presence of hepatic steatosis, presence of fat within the lesion, and adenomas are more encapsulated lesions. They won't have these lobular margins. So not one sequence is definitive, but if we combine all the sequences and our information, whether patient is on OC pills, if they have any risk factors for hepatic steatosis, then all these things help us to come to a definite diagnosis. And in still some cases, we can't come to a definite diagnosis. And in those cases, we'll need biopsy to give us the right answer.
Like in this case, this was the second MR. The first MR, I thought it was, when I first saw it, I thought it was an adenoma as well. And then they got an EOVist.
EOVist.
Then
Yeah.
then it was an FNH. So it's, yeah, I agree. It's a cumulative, you can really sort of use all these other morphologic features to help distinguish the two entities.
So Manjil has shared an AJR article for us to read. I think that will be really helpful. You can read it if we have multiple lesions. And Amar is asking, would be biopsy or just follow up in such cases?
I mean, this is
diagnosis is not certain and patient is asymptomatic.
Well, if you have a hepatobiliary phase, I mean, so if it doesn't take up, I don't know. There's very few cases where I have a diagnostic dilemma when I have hepatobiliary phase.
Yes, Manjil says if it's FNH, leave it. Yeah, if you're sure if it's FNH, it's a do not touch lesion.
Right, exactly.
We don't follow these, but if it's an adenoma, then that will require follow-up. And if it's more than 5 centimeters, they usually recommend surgical resection because there's risk of hemorrhage and malignant transformation. So if we can't be sure, if you have done EOVist and we are still not sure what this lesion is, then I think they will recommend biopsy. But I'm not sure if the patient is asymptomatic, then they will still do biopsy or not. But also if we have risk factors, like if the patient is on OC pills, then we have to also follow them after they have stopped the inciting factor. And if these adenomas sometimes will get smaller in size and some may even disappear. Amir's question is, how's everyone's experience with adenoma biopsy? Do they bleed? That would be a question more for people who do interventional radiology. I personally don't, so I don't have much experience in adenoma biopsies, but seen them quite frequently and not heard of major complications with adenoma biopsies.
This is Manjil. Sorry, I was going to say on the same note, sometimes if you're not sure on the, if it's, not hepatobiliary agent, then sometimes the T1 pre-contrast, if there's some blood in there, then that can be helpful for adenoma as well.
Yes, presence of fat and blood. But yeah, you can have fat in some rare FNHs too. But yes, that's why we have to take all sequences in consideration plus the clinical presentation and then try to come to a diagnosis. Okay, does anybody else have cases?
Hey, I have one case I can show.
Yeah, sure.
This is I'm Cameron. I'm one of the residents at Mayo, Arizona.
Hi, Cameron. Yeah, sure. Go ahead and share your screen.
All right. Can everybody see my screen okay?
Yes.
Awesome. All right. So this is a case that I had last year. Patient with a history of breast cancer and colon cancer, both low stage. Her colon cancer was treated with a partial colectomy. It was like 2 decades prior. So she presents to the ER with abdominal pain. And so as we're scrolling through here, you can see she looks like she's probably obstructed. She's got a lot of dilated small bowel. You can see her anastomosis. And so at the time this was reported as a partial small bowel obstruction. She ended up being treated conservatively with decompression and then was discharged home. She actually returned to the ER a couple months later with abdominal pain again. And this was when I was on call. And as we go through here, so we can see she's got another partial small bowel obstruction, it looks like. But on this study, we got, we were lucky they ordered with contrast. We can see everything a little bit better, but as we look closely in the mesentery, right in here, we can see there's some little nodules in the mesentery. And then because we gave contrast, much easier to see that there's a few lesions in the liver as well. And actually, the nice part about this case too is if we look back on the sagittal image, if we follow the small bowel through here, we can see at the point of obstruction, we actually have some asymmetric thickening in the ileum. And so the reason I wanted to show this case is this ended up, as we can see here, we've got liver mets, partial small bowel obstruction, some desmoplastic reaction in the mesentery. So it's a classic carcinoid tumor. And I think this patient got written off as an adhesive small bowel obstruction because of their history of prior surgery. But if we look back at the original exam, and we actually look closely, as you scroll through the mesentery here, you can see that we could have seen that desmoplastic reaction on the initial non-contrast exam, which should have kind of raised a few red flags there that this is not due to adhesive disease. And then if you actually window the axial images correctly on the non-con, you can see there are a few lesions in the liver that are visible even on the non-con. And so I just wanted to show this case because I think it's a rare cause of bowel obstruction, but I think it's not uncommon for a carcinoid tumor to present initially as a bowel obstruction. And I think it's related to that desmoplastic reaction, and it makes them obstruct when they're fairly small. Anyway, that's about
Yeah,
it.
interesting.
Great case.
Can we see that bowel thickening in axial? Like usually carcinoids, there's a small bowel mass and most of it grows eccentrically into the mesentery.
Yeah, so it's a little harder to see on the axial just because of the angle, but we can see it right here. And I think you might be able to see it kind of growing out into the mesentery right next to it there.
Yeah, and the mesenteric deposits are somewhat distant from the primary lesion.
Yeah.
Yeah, but yeah, as you said, like cases of bowel obstruction, it's so important to trace the entire bowel and identify the zone of transition. And at the zone of transition, we need to find if there isn't any obstructing mass or something focal that's causing obstruction. And if we don't see anything, and if we see sharp angulation of the bowel loops, then we suggest that it's probably due to adhesions. Yeah. And it's so important to have the right window setting to pick up these subtle liver lesions, especially if you have just one phase of contrast. Was there arterial phase on this one, or we just did uniphasic exam?
No, yeah, unfortunately, this was just ordered as a venous, only with
phase.
the venous phase routine, because I don't think they weren't expecting anything other than a recurrent small bowel obstruction.
Yeah, and so in those cases, it's even more important to get to the right window settings to pick up liver lesions. Yeah, nice case. Thank you. Manjil, your case is ready. You want to share your case? Manjil said he had one case, but maybe he needs time. So,
Hey, sorry. Yeah, I have it here. Let me just load it. Haven't gotten the MR ready yet. Oh shoot! Hold on. Don't.
yes.
Yes.
So this is a patient that 60-year-old gentleman who had some sort of rectal bleeding and then went for colonoscopy, and they found a rectal tumor, but that's not what's interesting. I'm going to do this one-on-one. So here's the rectal lesion. And they had done this for staging. There's an MRI to come to that I'm going to try to load at the same time. Sorry, it's a little bit slow. But so there's a rectal tumor here, and then there's another mass here. I'm curious what people think about this thing. And then I'm going to show the MRI after I scroll here for a second. Just try to show the chronology.
Might be an epidermoid cyst.
Ooh, that's a good thought. Like that. And here it is, it's along the left side, indents the piriformis a little bit there.
Amir said cystic hamartoma, retrorectal cystic hamartoma. Roopa said the same thing, retrorectal cyst spectrum.
Really good thoughts. Yeah. Like all this sort of like retrorectal presacral stuff is always like unusual. Like, you know, this one has a little bit of a unique feature here that I just want to kind of point out as it goes along the sciatic notch posterior to the piriformis here. There's a little bit of continuity.
Yeah.
Great thoughts. So here's the T2.
Yeah, there it is.
T2 bright.
Yeah, bright. And I'll show you the post contrast. I actually do have the answer to this. One of our colleagues showed this to me. Here's the post contrast. This wasn't done at our institution, so I don't know why this is not fat saturated, but this is just a the T1, and it does enhance. You know, if you compare the pre and the post like this, like side by side, all these areas do enhance, and then you know there's some darker areas on the in phase, and then some more solid components. So yeah, all those were good considerations. This came back a schwannoma.
Schwannoma.
Yeah, so you know, some of the tail here along the sciatic nerve, it really does follow the notch really well. And on some of these sequences, you get the sense that perhaps there's expansion of the nerve and then into this pedunculated lesion that's entering into the mesorectum. So I asked during the case conference, I was like, oh, did he have any nerve symptoms that found the rectal cancer, or did the rectal cancer find the nerve sheath tumor? And it was that the rectal cancer found the nerve sheath tumor. so it's good news for him.
Yeah, and I think the developmental spectrum that we were talking about, those are more midline. This one, we realized that it's slightly off to the midline, so we should have thought of other differentials as well. And we could clearly see the presacral or the peritoneal fat getting reflected away from it. And the other thing is these pelvic schwannomas, one of the terms used for them is ancient schwannomas, because they can grow to large sizes before they can cause symptoms. And since they have had time to grow, they develop areas of calcification, necrosis. They look very heterogeneous, but they're still well circumscribed and can grow to large sizes in this location. So those schwannomas are called ancient schwannomas.
Oh, that's really good feedback for me, actually, because, you know, when this was done, I was kind of surprised that this hadn't gotten discovered earlier from mass effect or something like this, but you're right, there's a big negative space there, certainly. So that's really helpful.
Yeah, they can grow to large sizes, and because they've been there for a long time, they will look very heterogeneous just because from the degeneration they've undergone. Yeah.
Yeah, and
cool case.
It was T3. So.
That was really nice. Thank you, Manjil. Okay, anybody else has any cases? Okay, then I can show mine. So 6 companion cases, they're easy. I'm just trying to show a spectrum. Can you all see my screen okay?
Yes.
Okay, so let me bring up the chat box so that I know people are. Okay, so a young female who's pregnant and presented with this incidentally detected adnexal mass, got an MRI for further characterization. That's the coronal T2 fat sat. Axial T2 fat sat. Axial T1. And then after we suggested something, so I just want to know what would your thoughts would be on this one. Don't have the chat box here. Okay.
Was it pedunculated, or I mean, it kind of looks like, I'm just trying to figure out what organ of interest we're looking at here. Is the ovary around? Like it looks like, yeah, further down there.
Yeah, the concern was whether it's an ovarian mass versus something else. So obviously, we know that either it could be an ovarian mass versus a pedunculated fibroid. That was the main differential. And we suggested that we saw some continuity here between the lateral margin of the lower uterus and this mass, and it had this little whorled appearance. So we suggested that this might be a pedunculated fibroid. So then after delivery, she had a C-section because she couldn't get a vaginal delivery because of this big mass occupying the lower pelvis. And these were the MR images postpartum. The sagittal T2, very heterogeneous mass, axial T2. So that's the uterus here. We could see both ovaries separate now. So the right ovary is here and the left ovary is here. And this is where the stalk is. So this was a broad ligament or a pedunculated fibroid. The only reason I'm showing this was there was an interesting histology on this case. So obviously this doesn't look like a very typical or usual leiomyomas, which are very T2 hypointense and have that classic whorled appearance. I mean, this one had whorled appearance, but it was not really T2 dark. It is very heterogeneous and has these areas of necrosis. There's some T1 hyperintense signal, which is so small that, I mean, can't tell if that's hemorrhage or some fat in it, because leiomyomas can degenerate and have a lot of heterogeneity within them. This is the post-contrast, enhanced pretty uniformly with small areas of non-enhancement. Those were probably the areas of either cystic degeneration or hemorrhage. At least one site showed hyperdensity here, and that area did not show any enhancement. So there was probably little hemorrhage. So given this marked heterogeneity and maybe small areas of hemorrhage and necrosis within the lesion, we were worried that this is something, yeah, no, this was not tossed because, yeah, it's enhancing very well. And this turned out to be, I mean, basically the discussion is on the lines of whether we can call it as a STUMP lesion, which stands for stromal tumors of unknown malignant potential. So the path on this one was leiomyoma variant, leiomyoma with nuclear atypia. And another interesting thing on this case was they did this immuno stain for fumarate hydratase, and that was negative. That means this patient had fumarate hydratase deficiency. So I wasn't really sure what all this means. So I did a little path review on these cases.
Leiomyomatosis, right? The hereditary.
Sorry, what, Nelly?
The fumarate hydratase mutation is seen with hereditary leiomyomatosis.
Yes, so this was a case of
RCC and aggressive leiomyosarcomas.
Yes, exactly. So that was the case in this one. This was a hereditary leiomyomatosis and renal cell carcinoma syndrome, because the leiomyoma was atypical and they had deficiency of this fumarate hydratase enzyme because of genetic mutation. And this syndrome is rare, characterized by variable presence of uterine leiomyomas, cutaneous leiomyomas, and renal cell carcinoma. The leiomyomas in these patients are more symptomatic as compared to the general population, and there's an increased risk for uterine leiomyosarcomas. And typically, leiomyosarcomas arise as de novo lesions. Very rarely, the typical leiomyomas will degenerate into leiomyosarcomas, but they're predominantly de novo. And RCC is only seen in up to just 25% of the cases, but whenever it's present, it's often aggressive. So that made me read about some interesting facts about the histology of these leiomyomas, like why do they look so different on imaging? And some are very classic and some are so heterogeneous. And like, when do we suspect malignancy in these cases? So just a quick review on histology of leiomyomas. What are these? These are basically on histopath, they see elongated spindle cells with variable amount of collagen in them that typically increases with age, that separate the tumor cells. And anytime a pathologist is evaluating a uterine smooth muscle cell tumor, they're looking for three histologic features. They're looking at the mitotic index, they're looking at the degree of cytologic atypia, and they're looking for presence of tumor cell necrosis. So based on this, the latest WHO classification has several subtypes ranging from a typical leiomyoma, leiomyoma variants, a stump lesion, and leiomyosarcoma. So they call something as leiomyoma only when the mitotic activity is really low, less than 5 figures per 10 high power field. There's just mild cytologic atypia, and there is no tumor cell necrosis. Then there are variants, which are cellular leiomyomas, which have just more cells, these spindle cells, but they don't have any of these features, like no mitotic activity, no atypia, and no necrosis. So they're just regular leiomyomas, they're just more cellular. Then you have leiomyomas with bizarre nuclei, which was in this case where you have basically cytologic atypia, but again, no increased mitotic activity or no tumor cell necrosis. And then there's this category known as mitotically active leiomyoma, which have just increased number of mitosis, but no atypia and no cell necrosis. So just one of these features is suspicious. The other two features are suggestive of a benign etiology. And then we have what is known as STUMP, which is a stromal tumor of unknown malignant potential that is somewhere in between benign and malignant lesions. So it's slightly more aggressive than leiomyoma variants, but less aggressive than a leiomyosarcoma. It won't meet all the criteria for leiomyosarcoma. So two of these three features are positive. So they may have increased mitotic activity and cytologic atypia, but no necrosis, or they can have necrosis and atypia, but no mitotic activity. And then leiomyosarcomas are the ones that fulfill all these criteria for aggressiveness. So no aggressiveness, just one feature suggesting aggressiveness is a variant. Two features suggesting aggressiveness is a STUMP lesion, and if all three features are met, that's a leiomyosarcoma. Now, can we differentiate that on imaging? That's the not so good point, that we really can't differentiate. So on MR imaging, a benign leiomyoma, it might be very hard to differentiate a leiomyoma from a leiomyosarcoma. Typical leiomyomas are easy. They're like T2 dark and lobulated and have their whorled appearance. They typically enhance. But even typical leiomyomas have a lot of degeneration in them, and then they look very heterogeneous. They can have cystic or myxoid degeneration. Or they're typically T1 hypointense, but if they have red degeneration, like if they bleed within them, then they will be T1 bright. But these other varieties of leiomyomas are all, they will have some degree of T2 hyperintensity. So that's when we suspect that either it's a, when it's not T2 dark, then it's probably not a classic leiomyoma. It either has to be leiomyoma variant, a STUMP lesion, or a leiomyosarcoma. Then there are some suggestive imaging features for leiomyosarcoma again, but these are not definitive. Leiomyosarcomas are typically large. They will have ill-defined and nodular or infiltrative margins. They will have areas of hemorrhagic necrosis. They will show marked heterogeneous enhancement. ADC might be helpful, so they will have more restrictions, so low ADC values, and they're typically seen in elderly. I think even this age also helps. Not really, you can get leiomyosarcomas in 40-year-old too, but typically younger the patient, less chances, unless they have genetic predisposition, they will have leiomyomas. And an elderly patient, if you have an aggressive looking mass, which had that whorled appearance, then it's probably a leiomyosarcoma. So limitation, standard MR cannot reliably differentiate between a leiomyoma undergoing benign degeneration and a leiomyosarcoma. But again, all these atypical ones have T2 hyperintensity, and they are more heterogeneous than these typical dark leiomyomas. And that suggests that there is a lot of scope for research in this topic, where we can pick up 20, 30 atypical leiomyomas and look at their histology findings and see if there are any suggestive imaging features. And the research is going on texture analysis. MR elastographies shown promising results in differentiating benign leiomyomas from malignant leiomyosarcomas. Spectroscopy theoretically can be used, and FLT PET, which is fluorine thymidate PET, is also helpful in differentiating a benign lesion from a malignant lesion. That's a good review article by Dr. Asher on whether we can differentiate benign leiomyomas from leiomyosarcomas before surgery. So you can have degeneration in the leiomyomas, can have cystic and myxoid degeneration. Both will look T2 bright, but cystic areas don't enhance, but myxoid areas enhance. And that's how we differentiate. If something is T2 bright, then is it the cystic component of the lesion, or if it's the myxoid component of the lesion? And fatty leiomyomas are T1 bright, and they will sat out on fat sat images, and hemorrhagic leiomyomas, which have red degeneration. The term used is red degeneration, and they are typically T1 bright. And then leiomyomas can have this unusual growth pattern. They will spread like malignancy, but on path, they are just benign, ordinary leiomyomas. They can be dissecting. And we've seen one variety of dissecting in our case conference, the cotyledonoid form, which looks like placental tissue. or it can extend into the veins and can spread. So that's IV leiomyomatosis, and you can have benign metastasizing leiomyomas where you have multiple masses in the abdominopelvic cavity in a young female, and that's one thing that we can think of as just benign metastasizing leiomyomas. Another controversial or difficult area with these leiomyomas is when you have these subserosal pedunculated leiomyomas, and we have to differentiate it from an ovarian mass. So you got to look for two features. We got to find the continuity of this adnexal mass with the adjacent myometrium, and if we find a separate normal ovary, then it's easier to say that it's probably a pedunculated leiomyoma and not an ovarian mass. As we saw in that case, we could later on see the normal ovary separately, and there was a little stalk connecting to the uterus. So that was just a quick review on the histology features of leiomyomas and how pathologists differentiate, and if we can differentiate those on imaging. So I'm just going to show you some.
Sorry, the renal cell that shows up with these familial hereditary type is type 2 papillary RCC. You know, we typically think like papillary RCCs are indolent, and those are usually the type 1, but patients with the hereditary adenomyomatosis, they get type 2 papillary RCCs, which are very aggressive. So they'll metastasize even though they're really small.
Yeah, oh, I didn't know that. That's nice to know that they get type 2 papillary RCCs. Amar is asking, why did they check for this fumarate hydratase gene in this patient? Is because they found nuclear atypia, which was unusual for a young patient to have. And also she had family history of leiomyomatosis. So that's the reason why they checked for this genetic marker. And the leiomyoma, when the OBGYN surgeon came and discussed this case, and what we said, it looks very heterogeneous, like it has areas of hemorrhagic necrosis that suggest some degree of malignant potential in those cases. So they went ahead and did that gene. This is another case. These are just simple, straightforward, but had very classic imaging findings. So I'm just like to complete the review of different types of leiomyoma. So any thoughts on what this could be? So pregnant lady who presented with acute abdominal pain. That was the coronal T2. That's axial T2. Get rid of these measurements. That's the out of phase imaging. Consider that as an T1, axial T2 fat sat. So any thoughts on what this is?
It was like just degenerating, right?
Yeah, so that is red degeneration, a hemorrhagic degeneration of a leiomyoma. So patient has multiple leiomyomas. The other ones look fairly typical, like T2 dark, globular margins, but this one is more T2 dark and is T1 bright. And red degeneration is classically described to happen during pregnancy because of alteration in the hormones and the blood flow. I think the effect of progesterone, and then you get this red degeneration of fibroids in pregnancy. Another one. This is a young female, 20, this is an unfortunate case, just 20-year-old who presented with menorrhagia, and she was bleeding so heavy that she was anemic and had to receive blood transfusions for it. So they did an endometrial biopsy on this one, and it was not definitive, but there was some concern whether this could be an endometrial polyp. So scan was done to see what this abnormality is. If we thought if it was more of a myometrial abnormality or an endometrial polyp. So those were the sagittal T2 and axial T2 images. This is sagittal post-contrast here. Coronal haste. So any thoughts on how would you all read this case?
I mean, it looks like an intracavitary to me. I mean, I want to say, I mean, could it, I don't know. There's like all this edema and stuff. Is it torus or something? I don't know. There's a stalk that posteriorly right there.
Yeah, so that's where the something like stalk is. So here, because the question was first, their first, sorry, what?
Do you have DWI?
Yes. That's ADC, and then I can go back to the higher p values here.
It's not really that restrictive.
Yeah, it's not really restricting. So here on the haste, we could see the endometrial cavity displaced to the left. Then we were more confident this is predominantly a myometrial problem. So it's not an endometrial problem, but an myometrial mass. So if there is a myometrial mass in a young patient, obviously, then we thought this is some form of an atypical or a degenerating leiomyoma. And that and they tried to do a myomectomy for this. They were trying to remove it, but the only unfortunate thing was like this is where it was firmly stuck to the deep myometrium and very closely involving the endometrium. So they were not able to salvage the endometrium. So they eventually did an hysterectomy for this 20-year-old young girl. And this one turned out to be a fibroid with myxoid degeneration, because all this is cystic degeneration. So this probably some of the cystic areas that are not enhancing are cystic degeneration. And then on the gross pathology, they found areas of myxoid degeneration too, probably like this one, which is T2 bright and enhancing. So this was a leiomyoma. So the diagnostic clues were a young patient with a myometrial lesion, probably think of just a leiomyoma with degeneration. That's when they look atypical like this. Another case. This one is a simple, straightforward, just interpreting different sequences. Again, a young female with this is a sagittal T2 image, and all we have to do is to interpret the signal intensity of this lesion. T2, that's my T1, and that's my pre-contrast T1. So that's yes, so that's a lipoleioma. So leiomas can have fatty degeneration in them. And if we see something that is T1 bright within the lesion that sats out, then we know there is fat in this. So there was a just very nice classic imaging features of a lipoleioma. In this case, again, all of these cases are in young females. This one was for, again, maybe pelvic pain, and ultrasound was done, showed an adnexal mass. That's my sagittal T2 image. That's axial T2. Scroll from the top downwards. That's uterus, that's the mass. That's the right adnexal. Follow the broad round ligament here on the right. It's the round ligament on the left. I can see the stuffed off vessels. We couldn't identify ovaries separately in this case. So, and I think this enhanced uniformly. Any thoughts on what this could be? So I have two answers here. Both of them said fibroid, parasitized fibroid. Yes, that's a possibility, but this one turned out to be an ovarian fibroma. And again, because couldn't identify ovaries separate from this lesion, and there was no stalk that we could see that was arising from the uterus for this lesion. So you can actually see the uterine serosa being completely separate, and sometimes, yeah, they do parasitize. It will be hard to differentiate, but I mean, the path on this one turned out to be an ovarian fibroma. And then companion case, you know, I've already showed this one. Yeah, this one. So again, we have an adnexal mass here, sagittal T2, axial T2. Coronal haste. Axial T1. and then post-contrast, that most of it enhanced, and then there were these areas on the top that did not show much enhancement. So again, here the question is, because it's an adnexal mass and it has this whorled appearance, is it an ovarian lesion like a fibroma or a fibrothecoma, or is it an pedunculated fibroid? So here actually we can see the stalk really well. We can see that the uterine serosa is discontinuous, and you can see that that's the stalk that's supplying, and you can see all the myometrial vessels extending to the base of the lesion. And the ovaries are separate in this case. So this was, that's the other ovary on this side. So this was a broad ligament fibroid. So to differentiate, as I said, like between a broad ligament fibroid from an ovarian lesion, if we can find a stalk and we can see the ovary separate, then you know it's a pedunculated fibroid, or else if you don't see the ovary separate, you don't see the stalk, then one of the diagnoses that we can suggest is a fibroma or an ovarian fibrous lesion like a fibroma or a fibrothecoma. And then we saw a couple examples of leiomyoma degeneration, red degeneration, myxoid degeneration, red degeneration, and heterogeneous looking leiomyomas where they have more T2 bright signals. So if they are larger, they have ill-defined margins, if they have areas of hemorrhagic necrosis in them, then and low ADC, that's when in an elderly patient, and that's when we can suggest a diagnosis of leiomyosarcoma in these cases. I think that's all I had, a quick review on leiomyomas.
Awesome cases.
Thanks, Nelly. Okay, I think you're almost close to two. Anybody else, any cases? Or else we'll stop here.
Thanks, everyone.
Thank you, Gitanjali.
Okay, thank you all. See you all next week.
Thank you.